Yeah. Hi. Good evening, everyone. Am I audible? Am I visible? Let's discuss the anesthesia questions that came in your exam. And just like how I told you last time when we were discussing anesthesia, that now you're getting a lot of questions from anesthesia in your FMG exams, also in your NEET and INICET. So, based on that, uh, what you can say trend, we have got seven proper anesthesia questions and one question which is an overlap between pharmacology and anesthesia, but I'll give it to the pharmacology because they are the people who usually teach you opioids, and I don't. So I have tried my best to get all the seven questions recalled along with their correct options that were given in the exam, but please feel free to add anything if you feel that I have missed out on anything or some information. But from what I understood is what, except one question, everything else was pretty much straightforward from the notes. One question was indeed a very, very intelligent question, and something that even made me think for a minute. And then, of course, we'll try and find out the correct answer. But I won't really be fretting too much about that one question. One question usually in the exam comes from something that we are not very well prepared or something like that. All right. So if you guys are here online, I would like you to just give me a thumbs up so that I feel I'm not talking alone. And yeah, hi, good evening, Ketan. So out of the seven questions, let's start with the first question. Which of the following waveform, what does the following waveform represent? And it was either a waveform that was given or it was a image of a monitor with an arrow, and that is again a PYQ from the past, uh, which was a NEET PYQ where they give the image of a monitor and asked you to identify the particular waveform. And since it was a square waveform which was moving along with breathing, so it tend to be end-tidal CO2 concentration. All right. So was it a monitor or was it a square wave? Yeah. So image was given. So this was given, right? A capnographic image was given, or it was a monitor. So whatever it is, you know that it was pointing towards something that was square wave, because you can get confused with pulse oximetry, but pulse oximetry would be like this, which will be pulsatile, and it would be related to the heart rate. While a capnograph would always be a square wave capnograph. And last year in NEET exam, we got a question where they gave a square wave capnograph and they pointed at this and asked what does this phase represent. So it was alveolar CO2, and we know that this is the expiratory upstroke, and downstroke will always go down to 0. So this is inspiratory downstroke, and we spend a fair bit of time understanding different capnographic waveforms. Okay, Ketan, thank you. This was the exact image you say. So they gave the image of capnographic waveform. All right. So that is something that was very expected and very straightforward. Which nerve is most used for neuromuscular monitoring during anesthesia? One recall that I got was straightforward where they asked directly the nerve. Another was where there was an image of a neuromuscular monitoring with ulnar nerve and adductor pollicis muscle. So what was it? Was it an image or a fact-based question? Irrespective of if it was an image, it became even more easy. But otherwise, also the most common nerve we use for neuromuscular monitoring is ulnar nerve. Again a PYQ. Again a PYQ. From about 5 years back, but again a PYQ. So they kind of did not really put too much of an effort. This time out of seven questions, six were from the PYQs. Image was shown. So I will add an image here. Image of neuromuscular monitoring, which was again not very difficult because the nerve that they showed must have been the ulnar nerve. So even if you did not know the right answer, you knew that they are asking about ulnar nerve. But suppose they go one step ahead and they ask, what is the second most common nerve used? Then your answer would be facial nerve. And the muscle it supplies is orbicularis oculi. The muscle it supplies is orbicularis oculi. Okay, done. A patient with maxillofacial trauma cannot be intubated or ventilated. What is the next most appropriate airway intervention? Was it the same recall? Is it something like this? Because this I got from multiple sources. Some said there was a CICO situation. Some said no, sir, there was a maxillofacial trauma patient where they mentioned that they could not intubate or ventilate the patient. So it is a CICO situation, but it is a CICO situation in casualty. But irrespective of what situation they give, this is a typical question related to the difficult airway algorithm. This was a typical question related to difficult airway algorithm. And we have discussed the difficult airway algorithm in terms of plan A, B, C, D. Plan A is always intubation. If you are not able to intubate, then you will go for SAD insertion. If you are not able to SAD, then you will go for final attempt at face mask ventilation. And finally, it was emergency cricothyroidotomy. Now, if they would have simply written that you are not able to intubate, then I would have been inclined to go for an LMA as a rescue device, although it's a maxillofacial trauma and LMA is not a very good device for patients with increased risk of aspiration, but they eliminated that doubt by giving both intubation and ventilation. So the correct answer would be emergency cricothyroidotomy. Okay, emergency cricothyroidotomy. So the correct answer was perform emergency cricothyroidotomy. Why not tracheostomy? Why not tracheostomy? Did it occur to anyone? Why not tracheostomy? See, tracheostomy is never a true emergency procedure. It will take some time. It will take some time. It is never a true emergency procedure, right? So you first do as a rescue airway device, you do cricothyroidotomy just to keep the patient oxygenated, eventually going to get a tracheostomy done. All right. This was also a very tricky kind of a question. An adult patient develops inspiratory stridor after extubation following prolonged ventilation. What is the most likely cause? Was the same question? Was it exactly the same question? Because again, initially I got someone said they just asked what is the narrowest portion of adult larynx, which was very weird to ask. Nobody asked narrowest portion of adult larynx, right? Who would ask narrowest? If they ask narrowest portion of a pediatric larynx, that is something unique. That is subglottic. But then people said, a lot of students said, no, sir. There was a clinical question. It was something to do with inspiratory stridor after extubation. So I thought then it would be child. But then they said, no, sir. It was very specifically mentioned an adult patient. So can an adult patient present with inspiratory stridor after extubation? Yes, he can. Ultimately, the mechanism would be same. In prolonged ventilation, your cuff can damage the subglottic area where the cuff is present, which can cause subglottic narrowing. Subglottic narrowing. All right. Ketan says it is child, but a lot of students were very specific. No, sir, it was an adult. It was not child. Patient is adult. Why? They were very specific because even I thought it is going to be a child. So ultimately, the mechanism is the same. What is the mechanism for not using a cuff tube in a pediatric patient? Is the same mechanism for an inspiratory stridor following prolonged ventilation in an adult patient. Prolonged ventilation, the cuff can damage tracheal mucosa, which can cause post-cricoid narrowing. Post-glottic narrowing. which will present to you with inspiratory stridor. Inspiratory stridor. Again, a very, very intelligent question. Like I told you when we were discussing anesthesia, that now they don't ask you very straightforward, dumb questions. What is this? What is that? Now they always want to put some clinical touch to it, right? Yeah, good, Ketan. Ultimately, what is important is whether you marked correct answer or not. Now, this was again expected question. Again, a PYQ. Patient under anesthesia develops hyperthermia, generalized muscle rigidity. Genetic testing reveals R1R mutation. Which channel is implicated in this condition? So they kind of always give you the most important thing, that is hyperthermia, rigidity. Here they also gave ryanodine receptor mutation. So the diagnosis is malignant hyperthermia. Malignant hyperthermia. And the correct answer is calcium. We know it is a defect of calcium channels, because ryanodine receptor basically controls the calcium channel. So the impulse causes the calcium to come out, causing massive muscle contraction, and ryanodine puts that calcium back into the via the calcium channel into the sarcoplasmic reticulum. So when there is a ryanodine receptor deficiency, it's a calcium problem. It's a calcium channel problem. All right. What is the function of the mark structure on the image? Some said mark structure on an endotracheal tube, some said mark structure on a tracheostomy tube. Doesn't matter. What matters is they pointed at cuff. They pointed at cuff. Is it used for suctioning of lower respiratory tract secretion? No. Monitoring airway pressure? No. Improves vocal cord visualization? No. Prevention of aspiration? Yes, Ketan, exactly. Hyperthermia was a giveaway. So that is the important thing, na, that they give the catch point. They don't create too much confusion. So what is the function of the cuff? Prevents aspiration. Also, what is another function? Prevents leak of gases. Prevents leak of gases, right? So it prevents aspiration and prevents leak of gases. Very good. All right. So far I have been okay on the questions, or you feel that they need some change? Now, this was the question that I was talking about, the one that had a catch. And this was a question that even I took some time to understand. First, I thought the recall is wrong. Then I thought the question is wrong, and then I realized what the examiner wants you to ask. So they have asked something that we normally do not go into that much detail. We look at the drugs that we use in daycare surgery, but they went into the indications and contraindications, and more so, they went into the recent change in the indications for daycare surgery. So with the rising cost of healthcare, now more and more guidelines are trying to include lot of patient subset and the surgery into the gambit of daycare. And this is why it is happening. I'm telling you the reason is because in US, most of the healthcare is insurance based. And now the insurance companies want to decrease the cost they're spending per patient. And that can be done if they discharge the patient very early. So they are putting lot of emphasis on understanding and finding out what is the extent to which you can discharge the patient on the same day. So based on that, certain guidelines changed recently. And so there was a patient posted for a laparoscopic cholecystectomy under general anesthesia. Which of the following makes the patient unsuitable for a daycare surgery? Unsuitable for a daycare surgery. So it has gone into indications. But even that could have been made little easier if they would have given us home is 45 minutes away. So the criteria is that it should be around, not very near, not very far. So no as such very hard fast criteria, but we consider about 1 hour drive is okay. Surgical duration more than 1 hour, 1 to 3 hours, that is okay. Most of the time, very long surgeries are not accepted, but okay, 1 to 3 hour surgeries are accepted. Then ASA grade 3, which is kind of a no-brainer. You would have marked, of course, sir, ASA 3 is uncontrolled systemic comorbidity, right? But here is the catch. Fourth option is no attendant available at home to take care of the patient. So this and this people even accepted that, okay, sir, this is not possible. But 3, most of you, including me, in the outset would always consider ASA 3 because daycare is always an elective procedure. So the idea is, if it is an elective procedure, why would I take an uncontrolled comorbidity? Yes or no? But then there is also that if there is no attendant to take care of the patient at home, then in case of an emergency, who will get the patient back to the hospital? So then when I dived into the guidelines, see, this is from the Miller's textbook of anesthesia. So let's just see that they have medical factors, they have surgical factors, they have social factors for which are responsible for the daycare surgery. And so what it says is that patient usually live within a reasonable traveling distance of the surgical unit, and reasonable traveling distance is about an hour, which is given in different guidelines. But look at what it has given below that in the next paragraph. The universal safety feature is to require all patients having surgery under general anesthesia or sedation to be discharged with a responsible adult escort, and the recommendation to have someone stay with them for next 24 hours. So according to Miller's textbook of anesthesia, this is like a must do. This is like a must do. You need to have a responsible adult. And in the paragraph before that, the page before that, they said that now the criteria have been relaxed. And now ASA is not an absolute criteria. Like ASA 3, you will never go for a daycare surgery is not the criteria. Because what they say is there are certain comorbidities which are managed better by the patient himself rather than the caregiver. For an example, asthma, hypertension, obesity. So you can have a BMI of more than 30, 35, who will then fall into the category of severe systemic disease, which is uncontrolled. But the patient is able to manage themselves better rather than patient being managed in the hospital. So what they are saying is now you can't say that ASA 3 is an absolute criteria that you will never go for a daycare surgery. So then that puts this question into the tricky zone, that they have asked something which is so detailed to the guidelines, which is practically impossible for us to remember. Practically impossible for us to remember. But yes, I would not say that you would always mark this option correct. And I would also not say that this would come very naturally to you in the sense of common sense. But yes, when you dive deep into the guidelines, then you realize that this is a better option. But I would definitely not consider this as a very, very easy question. And so what I did was I referred to another recent article that was written where there were contraindications to daycare procedures. So it was emergency procedure. So laparoscopic cholecystectomy can be done. ASA 3 patients and above with certain exceptions. So they are also mentioning now there are certain exceptions that ASA 3 would not be absolutely a contraindication for daycare surgery. Then poor cardiac risk such as failure, significant arrhythmia, severe aortic and mitral stenosis, obstructive sleep apnea, long duration extensive procedures, major laparoscopic surgery, again a gray area. Lap chole is considered a minor laparoscopic surgery, need for transfusion, postoperative ventilation, severe postoperative pain requiring intravenous analgesia, and lack of hospital backup. That means too far. And there is one more criteria which I just showed, that is not having a responsible adult to accompany. Okay? So this is not a question that I would tell you that you got it wrong. This is actually a very difficult question. So do not beat yourself up over this one question. But apart from that, the 6 questions that came were very, very easy and came everything from what we discussed. So I hope and I pray that you marked all 6 of them correct. Like I tell you, anesthesia is an easy subject for your exam. And so I hope that these made that difference in your exam and you are 6 nearer to your goal of 50% correct answers. And if you feel that there is anything that I've missed, you can always get back to me on Telegram or Instagram. You know my handle, Anesthesia Shorts by Anshul. And so you can help me. Another question, patient was intubated, but after some time, patient vitals were unstable. In the options I marked ET displacement, can't recall other options. Okay, I haven't got a question like this. Very vague kind of description that okay, I'll try and find out about this question. If at all, I'll put it up again. Okay. Vitals unstable, did they say what vitals unstable, whether it was saturation or it was BP, pulse, what it was when you say vitals were unstable? Anyway, I'll try to find out if I get from somewhere. But apart from that, it was a very, very doable kind of anesthesia part. All right. So thank you so much and God bless you. And yes, be in touch. We are going to see you very soon on the other side for NEET PG preparation. All right. Bye. Good night.